It's Tim and Brandon. We're here for Friday Facebook Live. The good news is the week is over, at least for most of us. Dr. Steele is headed off to Logan College this week.
I'm really excited for that. I know Becky's already over there. Should have some fun time at the seminar. There are some heavy hitters there, a lot of great speakers, and then I'll be speaking on Sunday, and then you're going to be in Kansas.
How did you get invited to that?
I paid someone off. Thanks, Bobby.
I wasn't even able to make that cut. Thanks, Bobby. But I will be at Kansas, in Kansas City, for the Kansas Chiropractic Association. We've got the orthopedic diplomate class, and whether you want to be a diplomate or not, we'll provide some good information about back pain. But what we have today, we are headed out of here quickly, so we're going to make this a quick Facebook Live. We thought about what are the most potent 2-second tests that we could talk about, and what are the specifics of those tests. So our favorite, if you've watched us in the past, you know that we love the arm squeeze. That a lot of times it's difficult to determine, is a patient's pain arising from shoulder pathology or is it arising from the cervical spine? Everybody has pain in the lateral shoulder radiating out to the deltoid tubercle, and once you hear that history, you know your differential is now narrowed to 200 possibilities. But the big differentiators are neck versus arm. So if it's coming from the cervical spine and it's not a radiculopathy, it could be sclerotogenous referral. And in that case, that nerve is probably sensitized, causing that referral of pain. And the way that we determine it is aggravate the nerve. Anytime we have a sensitized nerve, whether it be a carpal tunnel or a pronator teres, the way we test it is poke on it. And this is no different. The arm squeeze test, 2 seconds, squeeze the patient's arm enough to leave a little bit of a dent or take the blood out and see, does that hurt. If it hurts, that is 96% sensitive for somebody having a cervical radicular complaint as opposed to shoulder pathology. Doesn't mean they couldn't have both, but we need to address the neck.
One of my favorite tests. It's hard for him to do with small hands, but otherwise it's a pretty good test for most of us to do. But one of my favorite tests that I actually did this morning was, I had a patient come in and they're wondering about their hip pain, and I always perform the C sign, and the C sign is when they come in and say, my pain is right here. And what we found from a 2004 study is that there's a 98% chance that that problem is due to an intra-articular issue. So when patients come in and say they have pain here, especially radiating into the groin, you should be looking at the actual hip. But how do you make that differentiation between an intra-articular problem versus an extra-articular problem? And I use the single leg squat. So a lot of times they're going to have pain right along the posterior aspect of that greater trochanter, because most common diagnoses are a gluteal tendinopathy and overuse of those muscles that are trying to stabilize the hip. So they stand on one foot, and normally it doesn't hurt them too much. But as soon as they try to squat down, those butt muscles are trying to prevent that internal rotation, that internal spin and adduction of the femur, and you'll get pulling on that tissue, and it'll reproduce that pain. Very, very rarely am I going to see a pain that presents in the groin when I do that. If I were to see a groin pain, especially upon a single leg squat, I'm probably looking more at a labral lesion.
Great test. One that we're all familiar with would be Finklestein's test. It's one of those few pathognomonic tests that if it's positive, we know that this patient has stenosing tenosynovitis. But the tip that we're going to share with you is this test can be divided into 4 components so that we can grade our progress. A lot of times when we do the full test, it's going to provoke even mild symptoms. So what we want to do is to see at which state of the 4 options does pain come on. The first state is simply just allowing gravity to let this patient's wrist drop down. Second state would be for the patient now to actively ulnar deviate as far as they can. The third step of Finkelstein's is for me to now passively ulnar deviate the wrist. And then the fourth, which is the classic maneuver, tuck the thumb in and do that. And if that patient has pain in this area, they certainly have de Quervain's or stenosing tenosynovitis.
And the last one we just added for this Facebook Live, because we had this present last week and we had a discussion on it about the heel drop test. We see compression fractures a lot. Compression fracture is one of those things that we can manage as chiropractors. We do a phenomenal job of managing them for those people who can tolerate conservative management. But doing the heel drop is great, especially if you want to torture someone with a compression fracture. However, there are some things that can really provide a little bit of light to you and your patient if you can help them, and that is make them abdominally brace. So when they do a heel drop test, we all know how to do that. Stay nice and relaxed, drop down on your heels. Does that reproduce your symptoms? If there's a compression fracture in there, it's going to light them up. They're not going to appreciate if they swing at you, duck. But now we can say, what can we do to help that person get out of pain and get them moving? You can actually teach them how to abdominally brace. So having your hands between their ribs and their hips, have them push out as you contract, just 10, maybe 15% contraction. When they hold that contraction and then they do a heel drop, they're not going to have the same pain. And the reason is because you're providing core stability. You're sharing the load. You're taking the weight distribution off that actual compressed disc and vertebra, and you're going to actually put it on the outside part of the canister or the core. That does provide you and your patient a little bit of hope. They have a strategy to get themselves out of pain. So one, teach them how to abdominally brace, but number two, put a brace around them. A soft brace works just as well as the hard ones. This is a very self-limiting diagnosis, so if we can get them through that symptomatic period, we can hopefully avoid things like vertebroplasty and kyphoplasty.
Yeah, and one of the things to remember on a compression fracture is a lot of times it is osteoporotic. So depending on the density of that bone, it may take anything from a hard fall on the buttock to a sneeze for that vertebra to go. But in 20% of patients with metastatic bone cancer, their initial presentation is back pain from a compression fracture. So we want to make sure that we always start with the worst possibility and work to the best rather than assuming that that patient simply has an osteoporotic fracture. Hope this information has been useful. We hope that you'll be able to join us either in St. Louis or Kansas City this weekend. Next weekend you are
North Dakota.
North Dakota.
15 hours.
So both of you can join Dr. Steele there in North Dakota, and I think that I'll be in Pennsylvania here very shortly. So thanks for watching. Hope it's been useful. We'll look forward to connecting next week.